I'll have to give a little background on a clinical trial called the VITAL trial. It was a phase 3 trial in which patients were randomized. Newly diagnosed AL amyloid patients with heart involvement were randomized to receive CyBorD or to receive CyBorD with the monoclonal antibody NEOD-001. Now, NEOD-001 is no longer being developed by the company. But in this trial, which began in, I believe, 2014, the second-line therapies were left up to the investigator. So if you had a patient on either arm who wasn't responding effectively after 2 or 3 cycles of CyBorD, you could treat them with melphalan and dexamethasone or lenalidomide and dexamethasone, or essentially physicians' choice. Part of the reason for that was that the trial was being overseen at the FDA in the United States by the cardiorenal section and not the hematology section. So indeed, when Daratumumab was approved to treat patients with myeloma in late 2015, it became an option for a significant fraction of patients on the VITAL trial who had more than 10% plasma cells in their bone marrow, meeting diagnostic criteria for myeloma. And therefore, we treated a series of patients on the VITAL trial with Daratumumab. Now, the VITAL trial was a randomized prospective double-blind trial, so we did not know the patients were getting NEOD-001. But late in 2018, after the trial had been closed by the company because of a futility analysis, and despite the fact that the hazard ratio for those who got CyBorD plus NEOD-001 was 0.84, suggesting a possible benefit, the code for the trial was broken. And this allowed us to look at those patients who had received both NEOD-001 and Daratumumab. Now, what's interesting is that when we decided to treat patients with Daratumumab, we had to juggle the infusion schedule. So we came up with a schedule where patients received NEOD-001 on day 1 and could receive Daratumumab starting on day 3. And we split the dose of Daratumumab to avoid infusion reactions. So patients received Daratumumab usually on days 3 and 4. It was extremely well tolerated, and the combination was extremely active. We've published the series in a brief article in January of this year. And what's most interesting to us is the rapidity in which these patients who had not responded initially to bortezomib-based therapy responded to the combination of Daratumumab and NEOD-001. We believe this may have something to do with the influence of Daratumumab on T-cell subsets, enabling NEOD-001, which was binding, we think, to soluble amyloid fragments as well as to amyloid deposits, and enabling that monoclonal to work better. The tolerance was extremely good, and the time to hematologic and organ responses was extremely short. So we're hopeful that as new anti-amyloid therapies are developed, that attention will be paid to a role for the use of 2 monoclonals in patients who are quite ill. They have cardiac involvement with amyloid, but they tolerated receiving 2 monoclonal antibodies extremely well. As luck would have it, there are 2 trials opening in the clinical arena now, sponsored by Calum and Alexion. And those trials are trials for stage 2 and 3A cardiac amyloid newly diagnosed and stage 3B cardiac amyloid newly diagnosed. And patients will be randomized to receive KAL 101 with CyBorD or CyBorD alone. And if after 2 cycles they don't have a good response, their light chains don't come down significantly, they can switch to alternative therapy, and Daratumumab is permitted. So we'll get more information on the use of dual monoclonal antibody therapy in this patient population over the coming years.